And it's now my pleasure to introduce Pietro Lampertico, that will give the next talk on lessons learned from Bulevirtide. Pietro Lampertico is Professor of Gastroenterology and Director of Gastroenterology Pathology Division at the University Hospital of Milan. And he has a long-lasting track of excellence in clinical management of chronic viral hepatitis patients, in particular chronic hepatitis B and Delta. And he participated and is leading clinical research in all chronic hepatitis diseases, and also on the long-term outcome of cirrhotic patients undergoing antiviral treatments, in particular the follow-up of patients developing liver cancer after HBV suppression. And now is up to you, Pietro.
Thank you very much, Massimo. Can you hear me?
Yeah.
Can you see the slides? Okay, thank you very much, Massimo. Thank you very much, Maura, all the moderators, and the organizing committee, of course. So as mentioned by Heiner, I will cover in the next 15 minutes sort of summary of Bulevirtide data. These are my disclosures. So just to make a strong point, I will cover only Bulevirtide data, but as suggested by Heiner, there are many additional possible antiviral targets against hepatitis delta. Already mentioned interferon, alpha, but possibly also lambda in the future. siRNAs already showed some data from Heiner. Lonafenib boosted ritonavir, already another option. Nucleic acid polymers, and also many studies, or some studies, on monoclonal antibodies against S in hepatitis delta. So my job today is to cover only Bulevirtide. Why Bulevirtide? Well, Bulevirtide has been approved by EMA, as you know, in 2020, a 2 milligram sub-Q injection every day. Is the first ever drug approved by EMA, not yet approved by FDA, by the way. The mechanism of action is absolutely unique. It's an entry inhibitor. Right-hand side, you see the mechanism of action of Bulevirtide. Basically, by using this synthetic polypeptide, the entry of the Delta virus into the hepatocyte is stopped, and the spreading of the virus into the liver is also stopped. However, please remember in yellow here that Bulevirtide does not directly inhibit Delta replication in the infected cells. So that's a very important point. The kinetic of RNA decline is probably related to other kind of variables, cell turnover, cytotoxicity, viral induced, or immunoelimination. So this is something I don't want to go into much details, but that's a unique feature of this drug. And this is something that we have learned in the last couple of years. What also we have learned in the last couple of years is the efficacy in terms of virological, biochemical, and combined response rates over 1 year of Bulevirtide monotherapy. And these are the data from the registration trial, New England Journal of Medicine, Heiner, Wedemeyer, red bar, and 4 or 5 different clinical studies, real-life studies in Europe, because this drug is available in Europe. And the overall measure is that we have learned that the virological response is about 70%, biochemical response approximately 40 to 50%, combined response approximately 40 to 50%. The good news is that all these responses are very similar in registration trial and real-life data. Very good news is that the response in cirrhotics, compensated cirrhotics, is similar to patients without cirrhosis, with just chronic hepatitis. The good news. However, you see in yellow down here, there is a 20% of the patients with what we call virological non-response. We can play with this definition, we can discuss on this, but this has been basically confirmed in many different studies. And also only 10, 20, maybe 25% of the patients actually over 1 year of Bulevirtide monotherapy will achieve PCR negativity. So why only this small amount or limited number of patients really achieve possibly the best endpoint in any therapy in hepatitis delta? And these are challenges from this antiviral therapy. Another very important point I'd like to make is are the new data from EASL. In the previous slide, I showed you the virological response rate, but I did not mention S antigen decline because basically there is no S antigen decline or S antigen loss over 1 year. So this is not a short-term monotherapy. This is probably a long-term monotherapy. And if you prolong therapy from year 1 to year 2, these are the data from the 301 study presented for the first time at EASL meeting a few weeks ago. Again, please concentrate in the green dark bars or 2 milligram monotherapy. And the message is very simple. The longer you treat the patients, the better are the combined response rates, some improvement of the virological response rate, and also an improvement of biochemical response. And also in terms of PCR negativity, 12% over 1 year to 20% over year 2. So basically, the longer you treat with monotherapy, the better are the results. However, there is one challenge here. Although overall, the 10 milligram data, which is not approved dose, look very similar to the 2 milligram data. If you really look carefully at the PCR negativity data, there is some maybe indication that if you look specifically to this endpoint, maybe 10 milligram could be a very interesting dose. So the question is really 2 milligram the optimal dose of bulevirtide monotherapy? And this is something, is a challenging question. Probably we don't have enough data for now. What also we know from the French study is that if you prolong therapy, bulevirtide monotherapy up to year 2, there is a progressive increase of the virological and biochemical combined response rate. So this is true also for real life data. But in the French people, in the French cohort, they were also able to use a de novo combination with PEG interferon. And there are strong data suggesting that from the biological and virological point of view, there is a strong rationale to combine these two drugs because they are targeting 2 different kind of mechanisms of action, and they have different mechanisms of action, possibly with an additive or synergistic effect on delta. But there are very limited data, real-life data on this topic, and these data are suggesting that the initial virological response is better if you use a combination therapy. But if you prolong the combination therapy, actually the year 2 data are very similar to the year 2 data on monotherapy. So the challenging is any role for de novo combination PEG interferon, any role for add-on interferon, which is the best strategy. Again, I don't think we have enough data to make a strong conclusion. Well, what we've learned from the last 2 years of bulevirtide being available in Europe is that you can use bulevirtide in patients with compensated cirrhosis with or without clinically significant portal hypertension. This is data from EASL. We put together 167 patients, all with compensated cirrhosis from 37 different EU centers, Italy, France, Germany, Austria. And we showed a very good left side virological decline, even if it is difficult to manage patients. 3-log decline. On the right-hand side, a very good biochemical and fast normalization in most of the patients. Very good data. But the question, the challenges are the virological response in individual patients. If you look at the range, the RNA decline goes from 0.3 logs only over 3 years to more than 6 logs decline over 96 weeks. So a huge difference. You might think that compliance is relevant, probably in some of the patients, yes, but I think there is something else. There is a significant individual variation in terms of virological decline on bulevirtide monotherapy. This is something that we have to really think about. And also another very important point is ALT response can be even faster than the virological response. And, we have to think about the mechanism of action of this. And sometimes biochemical response is disconnected from virological response. And this is another very good point for hepatologists, but it's challenging somehow. What we learned in the last couple of years, mainly from EASL, is that if you treat with bulevirtide monotherapy patients with cirrhosis, and these are difficult to treat patients, you might see virological improvement, biochemical improvement, but also improvement of albumin levels. And actually, what we showed recently, very low rates of decompensation over 2 years in these patients, but no major changes probably of cancer. So for the first time, we start to see some clinical output, clinical endpoints on bulevirtide monotherapy. This is something new. But what is also new from EASL is the possibility, although this is off-label use of bulevirtide monotherapy, to use bulevirtide monotherapy in patients with mild liver decompensated, mild decompensated cirrhosis, which means child B, significant decline of viremia, significant improvement OLT, with 27% of the patient with clinical improvement and 27% of the patient with improvement of ascites, no major issues in terms of safety. Again, please remember, this is bulevirtide monotherapy in child B patients is off-label. We need a study in these patients, in my view. What we've learned also from the last few weeks, really on bulevirtide monotherapy, is that this drug is effective and safe in patients with triple infection, HIV positive, B positive, of course, and Delta positive. And these are the data from France, looking at 14 patients treated over 1 year with excellent virological and combined responses, 50% PCR negativity at year 1. These are the best ever result in terms of virological response on bulevirtide monotherapy. While our French, colleagues and friends suggested it was the first ever real-world data, but actually in Italy, there is already one published paper already putting together 14 such patients, not only showing efficacy and safety of bulevirtide monotherapy, but probably, in my view, for the first time, a progressive increase of CD4, CD8 cells, which is very relevant and very interesting. Again, what we've learned with bulevirtide monotherapy for the last couple of years is very safe. It's very safe in phase 2, in phase 3, for 1 year, for 2 years. It's very safe independently of the severity of liver disease. We do see those increase bile acid levels, but mainly and almost completely fully asymptomatic. And these are good news. However, again, challenges for bulevirtide monotherapy long-term, which are the long-term safety consequences or effects of elevated serum bile acids for 1, 2, 3, 4 years in cirrhotics. This is something what we do not know. And why the increase of bile acid levels is dose dependent, but not related to efficacy. This is something not completely clear. So probably the most important point is, can we stop bulevirtide monotherapy? Can we cure Delta without S antigen loss? And these questions will be addressed by the MIR-301 study, the registration trial that all patients after 3 years will stop bulevirtide monotherapy. But these data will be available probably in 1 or 2 years. So there are 2 studies showing that it is possible to stop bulevirtide monotherapy. This is one case from Italy. I'd like to thank Marwa Dandri for doing a lot of virology on these samples. What we showed is that we stop after bulevirtide monotherapy of 3 years. The patient remained PCR negative in the blood, but also in the liver, despite remaining S antigen positive. So it's possible to cure Delta with bulevirtide monotherapy. But what is very recently is a brand new data, brand new study from Austria. I don't have the time to go through the study, but what they did, they identified 2 patients treated with bulevirtide monotherapy, rather short period, and they remain PCR negative off therapy. Again, it's possible to achieve cure of Delta without cure of B if you treat with bulevirtide monotherapy. So in summary, ladies and gentlemen, we had no EMA or FDA approved therapy for Delta for 43 years up to 2020. 2020, EMA approved Bulevirtide monotherapy, which is available in EU. We many data showing efficacy and safety in real life and registration and phase 2 studies. For most of the patients, is long-term monotherapy, but long-term does not mean forever. I think that we can stop in some patients if they achieve PCR negativity. Combination with interferon could be very, very important in selected patients. However, the drug also it kind of raised some challenges, some new questions, and overall, how can we optimize the efficacy of Bulevirtide monotherapy? Thank you very much for your attention.